Before beginning the physical examination, the examiner introduces themselves, clarifies their role, confirms the patient's identity, and explains the intended examination using patient-appropriate language. The examiner gains consent, offering to provide a chaperone if this is appropriate, and washes their hands. For a detailed description of how to prepare for a physical examination, refer to the course Preparation for Physical Examination. To perform a general examination, the patient is positioned semi-recumbent with the couch inclined to 45 degrees. Exposure is from the waist up, and the lower limbs and groins are also fully accessible. Underwear can be left on. A general examination allows the examiner to obtain an overview of the general condition and health of the patient, and also provides an opportunity to examine features that do not fall neatly into a particular body system. For the patient, it also allows a gentle introduction to the more involved systems examinations that usually follow. First, the examiner inspects the environment immediately surrounding the patient for any clues as to their health status, such as the presence of mobility aids, medications, or smoking-related paraphernalia. In a hospital setting, the presence of monitoring equipment or oxygen delivery systems is important. Any charts, such as fluid balance charts, are looked at, and the examiner inspects the area immediately around the patient's bed for any adjuncts to treatment, such as catheters, peripheral or central venous cannulas, drains, or feeding tubes. A careful and systematic general inspection of the patient is next started, forming an initial assessment based on their demeanour and behaviour, looking for features such as restlessness, their level of engagement, and assessing their positioning. Do they look comfortable or not? Do they appear in pain? Do they look generally well or unwell? Traditionally, inspection is first performed from the end of the bed, noting the nutritional status, general volume status, colour, and overall respiratory status of the patient. Do they appear to be breathing comfortably? Are they clearly cyanosed, jaundiced, or pale? Are they grossly fluid overloaded or dehydrated? Are they notably under or overweight? The general examination now becomes more anatomically focused, allowing a systematic approach to identifying general features of systemic disease. Inspection of the hands is performed, looking first at the palms of the hands for any muscle wasting, palmar erythema, excess sweating, or thickening of the palmar fascia causing Dupuytren's contracture. The digits are examined for their temperature, colour, the presence of tar staining from smoking, and xanthomata. The nails are inspected, looking for splinter hemorrhages, spoon-shaped nails or koilonychia, and white discoloration of the entire or partial nail, or leukonychia. Assessment for finger clubbing is performed by asking the patient to place the nails of their middle or index fingers together and observing for a small, diamond-shaped window called Shamroth's window between the two nails. In finger clubbing, this window is lost to varying degrees. Assessment for asterixis, or a flapping tremor, can be performed by asking the patient to stretch their arms out in front of them and actively dorsiflexing the hands at the wrists, holding this position for around 30 seconds. A positive test causes a flapping motion of the hands, a type of negative myoclonus characterized by irregular lapses in posture. Moving from distal to proximal along the upper limb, the examiner inspects for bruising, excoriations, and needle track marks caused by intravenous drug abuse. The face is inspected, at first generally, looking for features or collections of features or facies, pathognomonic for specific pathologies or syndromes, such as Parkinsonism, Cushing's, scleroderma, or Downs. The colour of the face is also noted. The eyes and conjunctiva are inspected, looking for pallor, yellowing of the sclera, and the presence of xanthelasma or a corneal arcus, both signs of hypercholesterolemia. In the context of mediastinal pathology, the examiner can inspect ptosis, meiosis, and enophthalmos, signifying Horner's syndrome, arising from damage to the sympathetic trunk. The lips and oral cavity are next inspected, looking for, among other things, central cyanosis, aphthous ulceration, and angular stomatitis, and making a generic assessment of the condition of the teeth. In a number of examinations, palpation for the capillary refill time can give a useful indication of the cardiovascular status or the severity of acute illness. To measure this, direct pressure is applied to the nail or pulp of a digit, which is then quickly released, inspecting for a return of normal colour. A capillary refill time of 3 seconds or more is abnormal. Palpation of the radial pulse is also frequently included within a general examination, allowing the examiner to make a quick and rough assessment of the rate, rhythm, volume and character of the pulse prior to, if indicated, formal cardiovascular assessment. Does the volume feel normal or reduced? Does the rhythm feel regular or irregular? Does the rate feel fast or slow? An assessment of the lymphoretinacular system also frequently forms a component of the general examination and will be dictated by the lymphatic drainage of the specific area of interest. In surgical examinations, palpation of the supraclavicular fossae is frequently performed. On the left, looking to identify an enlarged left-sided supraclavicular node, known as Virchow's node, suggesting metastatic intra-abdominal malignancy. And on the right, palpating the supraclavicular group that drain the thorax and upper abdomen. For a detailed description, refer to the course Examination of the Neck. An assessment of the patient's fluid status also forms part of the general examination, examining for peripheral and pulmonary edema, the latter of which is described in detail in the course Examination of the Cardiovascular System. In the recumbent position, edema will often become less obvious around the ankles and more prominent around the sacrum and lower back. Sacral edema can be assessed by pressing the fingers into the skin over the mid-sacrum and observing for a residual indentation left at the point of contact. In ambulant patients, edema more typically accumulates around the ankles and distal lower limbs and can be likewise assessed using palpation. If present, pedal edema can be assessed by palpation from distal to proximal in order to define the level to which the edema extends. Measurement of the vital signs is now demonstrated. The respiratory rate is first measured by observing the patient's respirations for 30 seconds and then multiplying by 2 to calculate the number of breaths per minute. In a healthy adult, this should be between 12 and 20. A useful trick can be to measure the patient's respiratory rate while feeling the radial pulse, so that the patient is not aware that you are observing their breathing. Awareness of this can itself alter the respiratory rate. Peripheral oxygen saturation can be measured using a pulse oximeter, usually placing the oximeter over a fingertip. When recording oxygen saturation, it is important to note whether the patient is on supplemental oxygen or breathing room air. The heart rate can be measured by palpation of the pulse at the radial artery or via direct auscultation over the heart. Many electronic blood pressure cuffs and oxygen saturation probes now also measure the heart rate. The heart rate can be calculated by measuring for 30 seconds and multiplying by 2, or measuring for 15 seconds and multiplying by 4. If the rhythm is irregular, the heart rate should be measured for a full 60 seconds by auscultation at the precordium. Measurement of the arterial blood pressure over the brachial artery can be performed using a manual or automated sphygmomanometer, ensuring that the blood pressure cuff is the correct size for the patient's arm and that the marker of the cuff is lined up with the brachial artery. The diaphragm of the stethoscope is positioned over the artery and the cuff is inflated above the predicted systolic blood pressure. It can be helpful to estimate the systolic pressure first by palpating the radial pulse while inflating the cuff up until the point that the pulse is no longer palpable. The cuff is inflated to about 20 to 30 millimeters of mercury above the predicted systolic blood pressure. The cuff is then slowly deflated, listening for the onset of the first Korotkov sound. This reading is taken as the systolic blood pressure. The examiner continues to release the blood pressure cuff until the pulsatile sounds completely disappear. The final sound heard, signifying the transition from the fourth to the fifth Korotkov sound, is taken as the diastolic blood pressure. If the blood pressure reading is outside the normal range, it is good practice to repeat the blood pressure measurement and also consider assessing the blood pressure at the opposite arm. Note that measurement of blood pressure in the clinic setting is substantially inferior to home or ambulatory blood pressure monitoring. The patient's body temperature is also measured, normally using a tympanic thermometer. However, the exact method of use will depend on the type and brand of the thermometer used. Following completion or integration of a focused general examination and measurement of the patient's vital signs, the specific anatomical region or body system of interest can now be examined. For detailed descriptions, refer to the specific course for each physical examination.